This is a bit of a full-on slide, but I just wanted to get some idea of where historically myeloma has come in the last 170 years or so. And the first documented case was back in 1844 with a patient that I think her pictures are represented here. You can see how gnarled and broken the bone is. This is a picture of the sternum and how eaten out the bones are. This is the top of the thigh bone or femur, and unfortunately her body is quite a twisted mess, really. They attempted to treat her with rhubarb and orange peel, and there was another patient a year later treated with steel and quinine, and the steel and quinine in the patient actually had some response. They also used leeches, which inadvertently or intentionally must have removed a large component of the protein out of the blood for a while. They must have been extremely anemic afterwards, but they felt better and had some quality of life after that treatment. Unfortunately, these patients inevitably died within a short span of less than a year or two, I believe. We have a long gap in time before we have a description of what the plasma cells are, the actual abnormal cell. The abnormal protein was picked up as some funny gelatinous thing in people's urine of these patients before that. And then there are more studies looking at these proteins and realizing it's all very bad, but very little in the way of treatment right up until the 1950s. So we're only talking about a disease where we've had a really decent treatment for less than 60 years. And melphalan, which we still use to the very day as an agent either in high doses for transplant or in combination with prednisone in elderly patients, was discovered to be active in myeloma in around 1958. Steroids not long after that, and then it was found by Dr. Alexanian that the combination of both melphalan and prednisone were quite effective in cycles going every 4 to 6 weeks or so. And that really remained the mainstay of treatment for myeloma right up into the 1980s. At that stage, it was found that potentially returning people's stem cells after having high doses of melphalan would help them recover afterwards, and hence we get to the point of what we call autologous hematopoietic stem cell transplant or autologous transplant or autograft. They all mean the same thing, which still, as I said, remains part of the treatment regimen for people that are young enough and fit enough to go ahead to have it done. So that wasn't until the 1980s that was taken on, and it wasn't long in Brisbane that they started doing them here in both the private and public sector, and I know where I have my public appointment at PA, they started doing them in the early 90s. And we now do about 60 a year there of autologous transplants, of which about half of them are for myeloma, or just over half are for myeloma, I stand corrected. And then it wasn't really until the late 90s, around 1997, or published in 1999, was the use of thalidomide, and most people in this room would be familiar with the history of thalidomide in the late 50s up until 1961. It was a sedative thought to be good for morning sickness, but unfortunately caused horrific abnormalities in the unborn fetus, and it was available in Australia and in the UK, but was not approved by the FDA in the US, so they weren't affected as much as Europe and Australia were. But it was still being made, and someone, one of the patient's relatives suggested to Bart Barloghi, who's American and worldwide expert in myeloma, to use thalidomide for treatment, and it was effective in that patient, and he did a trial of about 84 patients soon after that, and had seen that it had stunningly better and less toxic responses than using melphalan or going ahead with transplant. It's now used in combination and a few other things, but that is only 14 years ago, so not a long time really in the history of medicine or the world, but and so beyond that, thankfully, we have now and this timeline was only up until 2008. It doesn't incorporate the last 4 years, but it was in 2002 that the drugs bortezomib and lenalidomide, known as Velcade and Revlimid are the brand names with these, that they were approved by the FDA in the US, hence usually available on trial here, and the main trial that we had going at the PA when I was a registrar was active from 2005, and that was our sort of first experience with bortezomib. Lenalidomide became available here soon after, but it's only been within the last couple of years which the Medicare, the PBS, have approved and paid for that drug, and well, for both of them I should say, and more recently have allowed for more easy access. And that is really where our new horizons are starting with myeloma, with the easy accessibility of these drugs, which we just simply have not had for any previous decade. So there was just, I've gone through all of those now. So as of 2009, the PBS, by way of government money, approved bortezomib and lenalidomide to be used in patients who'd previously used thalidomide for treatment of myeloma, or if people have had a transplant and the myeloma came back. With more and more studies showing that upfront treatment, particularly with Velcade or bortezomib, and it's only been within the last few months that we've had approval to use bortezomib upfront in treatment in patients, whether it be before having a stem cell transplant, or for those that aren't eligible for a transplant, to have it as their first line of treatment, and still leaving those other drugs down the track. So even though these were approved in the US early, and I just included Zometa, which is used for the bone here, it's taken quite a while for us to get easy access to these drugs. Beyond that, there are many more new drugs that are now available. Panobinostat, there was a panorama study that was going on at PA which looked at this agent. It doesn't really seem to be as promising as first thought, so we probably will be scrubbing that one from our list soon. But then there are two that are quite related to this drug, bortezomib, and particularly this one, which is in limited supply in Australia, and I'm not entirely sure of any active trials, but probably will be, give 5 or 10 years, will replace bortezomib. And say, well, if we've got a good drug that's working, why do we need to replace it? Well, it all comes down to, and if you're a patient yourself or got relatives, you know that really comes down to side effects. And the problem with bortezomib or Velcade really is its issue of causing peripheral neuropathy, or affecting the nerves, particularly in the feet, but also in the hands. It can affect the gut, it can affect the blood pressure control. You get fainting on standing. I won't go into it thoroughly, but unfortunately Velcade does have that side effect. We have found out that by way of giving it every week instead of twice a week, which was how it was usually given, that thankfully the side effect profile comes down, and now probably the next step with Velcade is, instead of giving it intravenously into the veins or through a portacath or into a PICC line in the arm, that potentially giving it under the skin may reduce side effects even more. What we call subcutaneous injection, we've got trialled undergoing at the PA with using subcutaneous bortezomib, and that will probably be the mainstay of treatment before too long too. It needs to go through an approval process again through the TGA, which approves drugs to be used in Australia, and then potentially for the PBS, the ones that pay for it will go through that process. But the thing is that these drugs, and particularly carfilzomib, may be even have fewer side effects and be more effective. And when we talk about classes of drugs, they find a first-in-class one, which is what bortezomib is, and then they keep working and getting better, fewer side effects, more effective, fewer treatments that will get the same effect. And that's where we're going with these two agents. Pomalidomide is a next drug beyond the ones that we're using now, which is related to thalidomide, as you can tell by the end of the name there. It's an oral agent or a tablet, and that would appear to be quite effective in patients that have had disease come back. So it's sort of a fourth or fifth line drug at the moment. There are antibody drugs directed towards little proteins on the surface of the plasma cells, and there are a few others as well, but I won't go into those in too great detail. This is getting a little bit more scientific, but just looking at the different classes of drugs, as I said, there is lenalidomide and pomalidomide, and thalidomide is in this group too. And all these ones that end in ib, which means they're inhibitors of this thing called proteasome inside the cell. The ones that end in ab are what we call antibodies or monoclonal antibodies. These HDAC inhibitors, as I said, probably will not be the great godsend they thought they would be. And then there are some old-fashioned drugs which they're throwing in again now. One called bendamustine may be effective, and mainly we reserve these drugs here for relapse disease, but there are more and more trials where we're looking at potentially using some of these up front. So there's, in terms of what's on the horizon, these certainly are ones on the horizon. These may be, and these as well. So they, or if not all of them, but most of them are in trials which are active in Australia, and particularly in Brisbane at PA, or within my private group, Icon Cancer Care. This is just a bit of a cartoon just to show at least one drug mechanism, being lenalidomide or Revlimid. Just because these drugs are not like classical chemotherapy agents which just go in like old-fashioned weed killer and go and kill lots of cells. That they're targeted treatments, and particularly this one, lenalidomide, is what we call an immunomodulatory drug. And it goes by way of affecting tumour suppressor genes inside the cell. It increases the immune reaction and then kills off the myeloma cell in a process that we call apoptosis, which just means a controlled cell death thing that occurs. And these all eventually, as it says down the bottom, leads to cell death and an immune response which kills off the plasma cells. So just re-looking at the outlook of myeloma, how we've changed, and even when I was a registrar, we used to learn from our consultants, you know, if you've got a new myeloma patient, you tell them their outlook is only about 2 to 3 years. If they're young enough, fit enough to have an autologous transplant, then they'll get another, maybe an extra 2 years out of that. When I say young enough with a transplant, we're continually stretching the limits. When people first had autologous transplants, generally they were limited to people under 50. This is back in the 80s. Then under 60 and 65 and 70. Now we're transplanting people up to sort of 75, and I know when you look at celebrities of people in these cancer centres in the US, they're doing them up to ages of 80. But generally, we try to limit it to people under 70. We know that the risk of dying of in the process of an autologous transplant is generally about 1 to 2%, meaning you die of complications of that high-dose therapy rather than of the disease. And we'd prefer to think it was something as low as that if we're going to put people into it. If it's looking at 10 to 20%, we'd prefer to look at alternatives. And as we see now, we've got lots of other options rather than giving people high doses of chemotherapy and returning their stem cells. Nowadays though, and with the changes in the drugs, we would prefer to suggest that people that are candidates for transplants now have an outlook of in excess of 10 years, maybe 10 to 15 years. It does depend on the case, person's fitness. There are other things called cytogenetics and FISH tests which determine outlook, so this is just a broad statement. I don't want anyone to say, oh, my doctor said I've still only got 5 years to live or something, but generally we're seeing these sort of numbers now, even just with the changes within the last 15 years. So for patients that are non-transplant candidates, generally the outlook isn't quite as long but generally they will be older patients and life expectancy is less anyhow. So, but look, in terms of comparative numbers of where we were even 8 years ago, we're looking at far better outlook. The current approaches to treatment now, particularly with the this is just off trial, and now particularly with the PBS access or the government paid access of drugs, means that we use usually a combination of these through 3 drugs: cyclophosphamide, bortezomib and dexamethasone. Even up until a few months ago, we used to usually use cyclophosphamide, thalidomide and dexamethasone. Thalidomide tends to be sort of pushed back later now, because we think that people will generally get a deeper, better response with bortezomib or Velcade. We do that for 3 to 4 months prior, depending on one's wishes, and then go ahead and give high-dose cyclophosphamide. So this drug, which is usually taken in tablet form, well, it will be tablet form till October, till they take it off the market in oral form, and it's given intravenously in a large dose. Then GCSF, or the stem cell stimulating factor, which we get the stem cells out of the blood, collected through a line in the neck or through cannulae in the arm on an apheresis machine, stored in bags, which are then stored in liquid nitrogen, and then when needed defrosted and put back into the veins, which is this autologous stem cell transplant, or reinfusion of stem cells, probably more accurately, because it's not a person-to-person transplant. But before that, we need to treat people with high-dose therapy, which is standardly melphalan, high dose of the drug given on one day, and the stem cells are given the next day. And this transplant that we've talked about does require usually a 3 to 4 week admission in hospital, with high risks of infection during it, but thankfully low risks of death compared to other procedures. Maintenance therapy then proceeds on that. Standardly, we continue to use thalidomide as maintenance, but maintenance regimens using Velcade or bortezomib are probably going to be more standard as we move on and have easier availability of it. So that one is certainly watch this space. And generally, maintenance therapies go for a year, and then we stop and watch. If patients are relapsing or the disease is coming back, then we look at further agents to treat the disease. Apology for the typo there, but induction treatment in non-transplant eligible patients. Again, our approach is changing, using Velcade or bortezomib up front, and usually we try and use melphalan in small doses, in tablets, combined with the intravenous Velcade and oral prednisone or prednisolone steroid tablets, and that's usually given in cycles, depending on the timing, every 5 weeks or so. And if Velcade or getting an intravenous drug is not favoured, or they've got problems with their nerves to start with, then thalidomide tends to be an easier option, and particularly in older patients where maybe turning up to a hospital or daycare setting every week still remains too inconvenient or difficult, so having an oral preparation in thalidomide may be favoured in that setting. There are many more that we could fill this space in, and if your family member, whatever, is not particularly on those ones, doesn't mean it's the wrong one. But classically, we have generally seen melphalan and prednisone being the combination of drugs that we've used, and this may be replaced with prednisone in any regimen. Melphalan prednisone has generally been the choice of treatment for those patients that don't have treatment with transplant before thalidomide came along.